What are advanced surgical techniques for bladder augmentation? Imagine transforming a small, stiff bladder into a larger, more flexible storage tank that works better and protects your kidneys. That's what advanced bladder augmentation aims to do. When the bladder becomes too small or non-compliant, surgery can help restore its function. Surgeons often use parts of the intestine to create a bigger, low-pressure reservoir for urine. These methods are carefully designed to improve quality of life and prevent kidney damage. One common technique is called augmentation enterocystoplasty. In this procedure, a segment of the small intestine or colon is taken out, opened along its length, and reshaped into a pouch. This pouch is then sewn onto the bladder's top, or dome, making it larger. The opening along the intestine is detubularized, which means it's cut open to prevent the intestine's natural contractions from causing high pressure. The new patch is shaped into a sphere or S shape to hold more urine comfortably. After surgery, patients usually need to use a catheter to drain the bladder regularly. Over time, the bladder can hold around 500 milliliters or more of urine, significantly improving storage capacity. Another advanced option is seromuscular enterocystoplasty. This technique uses only the outer muscle layer of the intestine, leaving the inner lining or mucosa behind. The mucosa is removed from the intestinal segment, which is then attached to the bladder. The bladder lining grows over the intestinal tissue, creating a low-pressure, compliant reservoir. This approach reduces the risk of metabolic problems like electrolyte imbalances or acid buildup that sometimes happen with bowel segments used in other surgeries. Ureterocystoplasty is another method that uses the patient's own ureter, the tube that carries urine from the kidney to the bladder. If the ureter is dilated or enlarged, it can be used to augment the bladder without using bowel tissue. Similarly, autoaugmentation involves creating a small pouch by removing part of the bladder muscle, allowing the bladder lining to expand outward. These techniques are less common but useful in specific cases where bowel use isn't ideal. In recent years, minimally invasive techniques have become more popular. Surgeons now perform bladder augmentation using laparoscopic or robotic-assisted surgery. These methods involve smaller cuts, which can lead to less pain and quicker recovery. The core steps remains the same: isolating and detubularizing bowel segments and attaching them to the bladder. Long-term results are similar to traditional open surgery, but patient selection is key. After surgery, patients usually need to perform clean intermittent catheterization to empty the bladder fully. A suprapubic catheter is often placed during surgery to help drain urine and support healing. If the patient has reflux of urine back into the kidneys, that can be fixed at the same time to protect kidney health. Monitoring for metabolic issues is also important because bowel tissue can sometimes cause electrolyte imbalances or acid-base problems. All these techniques aim to modify the bladder to hold more urine at low pressure, which helps prevent damage to the kidneys and ureters. They use the natural distensibility of intestinal tissue or native tissues like the ureter to rebuild a better urinary reservoir. The goal is to restore or improve bladder function, making daily life easier and safer for patients with severe bladder problems.